Hi, my name is Brian. This is my video presentation on hypovolemic shock. This is video 2 of my video presentation project. So, hypovolemic shock refers to a medical or surgical condition in which the patient rapidly loses volume and thus resulting in multiple organ failure due to the inadequacy of the circulatory volume and the perfusion towards that, so the tissues don't get any oxygenation as well. So the endothelium plays a critical role in the vascular, physiological, pathophysiological, and reparative processes. The functions of the endothelium are highly altered following hypovolemic shock due to ischemia of the endothelial cells and by reperfusion due to resuscitation with fluids. Due to the oxygen deprivation, endothelial cells die and are induced following hypovolemic shock, and that's just a process in which it occurs. So to note, hypovolemic shock is secondary to rapid fluid loss or blood loss. So this in turn turns into a hemorrhagic shock. So to delve a little bit deeper into hemorrhagic shock, it can also result from significant acute internal blood loss, especially in the thoracic and abdominal cavities. It can also result in acute external blood loss secondary to penetrating trauma, and also severe GI bleeding disorders are two common causes of the hemorrhagic shock. So two common causes of rapid internal blood loss are solid organ injury and rupture of an abdominal aortic aneurysm. This can result to a accidental car crash or severe blunt force trauma to the abdomen. Two common causes of rapid internal blood losses are, as I said, solid organ injury, the rupture of an abdominal aortic aneurysm. The hypovolemic shock can result from significant fluid other than blood loss. So two examples of that would be to include the refractory gastroenteritis and extensive burns as well. So what are the pathophysiology and how does our body react to being in hypovolemic shock or hemorrhagic shock? The human body responds to acute hemorrhage by activating the following major physiological systems: the hematologic, cardiovascular, renal, and neuroendocrine systems. So the hematologic systems respond to an acute severe blood loss and thus activating the coagulation cascade. This is where the blood vessels are contracting. In addition to that, platelets are activated and form an immature clot on the bleeding source. This is usually common to what we find in normal bleeding, such as getting a paper cut or all the way to just losing a leg as well. The damaged vessels exposes collagen, and which subsequently causes fibrin depositions and stabilization of the clot. Approximately 24 hours are needed to complete clot fibrination and mature formation. The cardiovascular system initially responds to hypovolemic shock by increasing the heart rate, increasing myocardial contractility, and constricting peripheral blood vessels. The renal system responds to hemorrhagic shock by stimulating increase in renin secretions from the juxtaglomerular apparatus, thus secreting these hormones to end up with angiotensin II, which will cause vasoconstriction as well. The neuroendocrine system responds to hemorrhagic shock by causing an increase in circulatory antidiuretic hormones, which in turn decreases blood pressure. Next is imaging studies that aid in the diagnosis of hypovolemic shock, and in this next slide I'll be showing 4 different kinds. So the clinical presentations for hypovolemic shock, first you also want to take into account symptoms of shock, such as weakness, lightheadedness, and confusion should be assessed in all patients, no matter the clinical situation that they might be in. But for the diagnostic testing that we will see, or imaging testing that would help in diagnosis of the treatment of what type of shock it'll be, will be CT scans to assess the full body for any unknown internal or external injuries that could result in hypovolemic shock, bedside ultrasounds, a rapid bedside method to identify free fluid in the abdomen cavity, pericardial sac, and pleural space, making it valuable for initial evaluations for trauma patients with suspected internal bleeding. This might be one of the few of the rapid that you'd use. Chest X-rays are really good and time as well. Can detect any hemothorax or any blood in the chest cavity, although may not be as sensitive as ultrasound or CT scans. Pelvic radiographs can identify pelvic fractures, which may be associated with internal pelvic bleeding as well. In the next slide, we'll see certain examples and images of that as well. In this first example here, we have a CT scan, and the next one we have is an ultrasound. Not necessarily a bedside, but can be an example of a bedside. Here we see some pericardial effusion, I believe, indicated in this laser pointer here, because we have the ventricles, atrium. It's there. The next one we have a chest X-ray. Here is very evident of a hematothorax. There's just fluid and blood built up here. The lung tissue here being just blunted out. There's the angles are gone as well, and just this huge whitening in the center of the mass. Pelvic scan here, radiograph of the pelvic region. We have a few of these fluid bronchograms here, or like places where fluid is building up. So hemodynamic monitoring techniques and values relevant towards a hypovolemic shock would be one of the main things is do not rely on systolic blood pressure as the main indicator of the shock. This practice results in delayed diagnosis, and we're talking about life and death situations here, so we want to try to get that fast pace, that fast diagnosis. So until the patient has lost 30% of the blood volume, that's when you'll see that significant decrease in systolic blood pressure. So class 1 hemorrhage is a loss of 0 to 15% of blood loss. It's the absence of complications, only minimal tachycardia is seen, usually no changes in blood pressure, pulse pressure, or respiratory rate can occur. Class 2 is 15 to 30%, and this is usually you'll see a lot more symptoms here with tachycardia, just greater than 100 beats per minute, tach beat, decreases in pulse pressure, cool clammy skin, delayed capillary refill, and slight anxiety. So you have increased respiratory rate. Class 3 hemorrhage is a loss of 30 to 40%. By this point, patients will usually have marked tachypnea and tachycardia, a decrease in systolic blood pressure, oliguria, and significant changes in mental status. So start acting confused, not necessarily understanding where they're at. And patients without other injuries or fluid losses, 30% to 40% loss is the smallest amount of blood loss that consistently causes a decrease in systolic blood pressure. So again, that's not going to be your main indicator. These other symptoms will be, and then understanding the situation the patient was in before or why they are coming in. Class 4 is the most severe. It's a loss of 40% or greater. Pharmacological options and medications to improve the condition of shock and restore hemostasis. The goal of pharmacology therapy is to reduce morbidity and prevent complications. So anti-secretory agents, these agents have vasoconstrictive properties and can reduce blood pressure or blood flow to portal systems, such as Zecnil, which is naturally occurring tetradecaptide, associated with the hypothalamus and pancreas. Also, sandostatin is a well-known one as well. So the ABG anomalies in the hemorrhagic shock will include acidosis, hypoxemia, and base deficit. You'll see acidosis in pH below 7.35. These are tolerable early in the shock, but it can definitely go below 7.25, and then you'll have to interfere with catecholamine action and cause hypotension. Metabolic acidosis is the initial acid-base disturbance in hemorrhagic shock because you're losing all the fluid balances as well. Hypoxemia or low PaO2, you'll have inadequate alveolar ventilations due to that low perfusion, low ventilation mismatch. The hypoxemia may relate to hypoventilation or secondary to a disturbance in ventilation to perfusion. Base deficit can occur as well, so you have a significant decrease in base deficit during shock. You're losing bicarb, you're losing your electrolytes, things that you need to regulate your blood pH. Other ABG abnormalities is a decrease in pH from baseline to shock or a non-significant decrease in atrial PCO2 during shock. Your options for mechanical ventilation, it's going to vary quite differently. In the setting of hypovolemic shock, positive pressure ventilation, it does decrease venous return, and since we're already dealing with a loss of venous return and a diminished cardiac outcome, it could worsen your shock state. And while oxygenation and ventilation are necessary, having the excess of positive pressure can be detrimental for the patient and their well-being going forward. So what can we do? Patients' airways should be assessed immediately upon arrival and stabilized if necessary. So if they're going into shock, they're most likely going to lose consciousness. We're going to have to either insert endotracheal tube to manage their ventilation. The depth and rate of respiration as well as breath sounds should be assessed. There we'll see the clinical assessments of a hemothorax, and we'll see from there the pathology. So hemothorax or flared chest could be present, and that could interfere with breathing is found and should be addressed immediately. High flow supplemental oxygen should be administered to all patients. So in this case, that would not change, and excessive positive pressure ventilation can be detrimental for a patient as well. So a quick summary of my presentation. What we learned today is that hypovolemic shock is secondary to rapid blood loss, which is hemorrhaging shock. There we will see clinical assessments of the patient. We want to first identify their respiratory rate, pulse, observations there. If they're becoming cyanotic, we do want to take accountability what diagnostic studies that we can do. CT scans is going to be our most intensive one. We'll get a broader picture of where, how, and when the internal bleeding can occur or where it's occurring at the moment. Chest x-rays, bedside ultrasounds, and pelvic radiographs on which it can stop the bleeding. So then you have that coagulation cascade will occur in those regions where internal bleeding is occurring. Mechanical ventilation is not always recommended, as it can cause greater pressure to be constricting those greater vessels. So you'll get a decrease of venous return, and a decrease in cardiac output, which will then cause the hemorrhage shock to get worsened, as well as causing tissue death due to no perfusion and oxygenation occurring there. One of the main treatments for this patient would just be that balancing fluid intake, making sure that they are getting everything they need to correct their pH balances, to address the main issues at hand, either that's internal or external injuries or bleeding, and making sure that the patient is assessed correctly and has their airway patent, and making sure that they are given the right medications. That would be the anti-secretory agents to decrease any blood loss further going from the initial treatments. Well, this is my reference page as well. These are where I got all my information, and including all the reference to the scans as well. Thank you.